We are live now, doctor.
Okay, thank you. So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. I am Dr. Vishal Agarwal, Scientific Committee Chairman, ROS, and it gives me immense pleasure to welcome you all for yet another masterclass of the online postgraduate teaching program, Kaksha. So, Kaksha is a PG teaching program conducted by Rajasthan Ophthalmological Society, which is covering all major topics of the current curriculum of PG teaching in India. We bring the best of national and state faculty experts to share the knowledge and enlighten us, you, and interact with all the residents freely. The residents who have logged in are also encouraged to put forward their doubts in a fearless manner. They can they can raise their hand and unmute themselves, or they can ask the question in the chat box, and the speaker will be more than happy to answer them. And as usual, there is a grand quiz kept at the end of the class with lots of grand prizes to be won. So keep a strong vigil and stay glued to the class. Coming to this Kaksha, we have today with us my very dear friend and uh, VR surgeon from Chennai Arvind Eye Hospital, Dr. Anand Rajendran, to teach us about the relationship between hypertension and the eye, the intricacies between the two conditions. It is a very important topic, not just for the postgraduates, but also for all the practicing ophthalmologists. Dr. Anand Rajendran is a prolific VR surgeon, academician, and teacher par excellence. And I would say he's an authority on all things retina. He's a professor of ophthalmology and head of the VR services at Arvind Eye Hospital, Chennai. He was the convener scientific committee VRSI 19 to 2021 and did a stellar job for the same. He obtained his medical degrees from JIPMER, Pondicherry, and post-graduation from Arvind Eye Hospital, and has been trained at Bascom Palmer Eye Institute under Dr. Phil Rosenfeld, the Henny Eye Institute with Dr. Sadda, and at the Vitreoretinal Macula Clinic of New York under Dr. Yanouzi. He's the recipient of the IGO Honor Award 2023. He's on the board of various international retina societies like RWC, SOLS, and Witt-Bethel Society, and Fighting Retinal Blindness. He has an interest in anti-VEGF therapies, macular diseases, retinal vascular disorders, and of course, surgical retina. He has numerous publications, presentations, and book chapters to his credit. I welcome the ROS President, Dr. Sanjeev Desai, sir, President-elect, Dr. Virendra Agarwal, sir, and our dynamic secretary, Dr. Ghulam Ali from Jodhpur. Dr. Anand Rajendran, Dr. Pooja and Akshita will be your hot seat residents, and you can interact with them. They are both logged in. They are second or third year residents in various, teaching institutes in Rajasthan. Over to you, Dr. Anand, to share your screen and start the presentation.
I'll just share my screen a bit.
You can start, sir. You can share your presentation.
Yeah. So can you see my slide now?
Yes, sir. We can see.
Yeah.
You get full screen.
Yeah, I'm just about to do that. Yeah. So at the outset, I'd like to thank Vishal and the Rajasthan Ophthalmic Society for, first of all, bring up this show, which I think is excellent. I mean, we focus on fellows and faculty, but I think it's very critical. Can you see my slide, full slide?
Sir, we can see your full screen. No problem.
Okay. So it's an absolute pleasure to be talking to you today about hypertension and the eye. And this presentation of mine is going to be in large part based on an audiovisual presentation chapter which I had authored for this digital textbook called the Degenerative Text of Ophthalmology. And I'd like to extend my thanks to JP Brothers for putting up that stellar show and combining with Urban to bring that out. While we tend to focus on diabetes as the prime and the silent killer of vision, and the hypertension tends to fly under the wing, under the radar, and doesn't get its due, at least amongst ophthalmologists. But I think it's something that we need to look at seriously because it really is an accelerator and does a lot of damage in the eye. Let's see how that happens. And as Vishal mentioned, and all of you are used to, this is going to be a bit of an interactive kind of a class, not just a didactic. Let's see how we go. So the learning objectives for this class are going to be classification of hypertensive retinopathy, see and understand that, clinical features and grades of hypertensive choroidopathy, hypertensive optic neuropathy. So the hypertension doesn't just hit the retina, it also hits the choroid and the optic nerve, and we'll look at that. Complications and management of hypertensive retinopathy also. So let's begin with trying to actually define hypertension. So the students in the hot seat, Pooja and Akshita, would you like to quickly tell me how we define hypertension? When you see a patient in the OPD, and before you call them hypertensives, what is the standard definition given by WHO? What are the values for systolic BP and diastolic BP? Any one of you?
Good evening, sir.
Yeah.
Sir, systolic BP more than 140 and diastolic BP more than 90.
Yeah, I'm done. Good. So we get off to a good start. So that's very important to know. And I think it's very important that, when the patient walks in, it's important for you in your clinics to have yourself or have one of your colleagues or technicians, record BP. That's something that's critical to be done. Okay. So moving on. Now, the stages of hypertension have also been defined and are well understood. The seventh report of the Joint National Committee on Prevention, Detection, Evaluation, Treatment of the High Blood Pressure, JNC 7, stages hypertension like this. So you have pre-hypertension, stage 1, stage 2, hypertensive urgency, and hypertensive emergency. Pre-hypertension ranges from 120 to 139, diastolic 80 to 90, stage 1, 140 to 159, diastolic 90 to 99, stage 2, greater than 160, diastolic more than 100, hypertensive urgency, and hypertensive emergency, both systolic more than 180, diastolic more than 120. The difference being that target organ damage is only seen with hypertensive emergencies, whereas all the others don't have target organ damage. So this is something to also know and keep in mind. A few epidemiological nuggets. 40% of the individuals have greater than 25 years of age, are more than 25 years, and they may be hypertensive. It's unfortunate. Prevalence of hypertension by next year supposed to increase by about 24%, almost a quarter in developing countries and 80% in developed countries. And hypertension alone can account for about little short of 10 million deaths annually globally. So this is why it's important to know about hypertension and keep an eye out for hypertension too. A few red flags, epidemiological red flags. So well-controlled hypertensive patients on antihypertensives, even if they're well controlled, but if they have moderate to severe retinopathy, they will have a threefold higher risk of stroke. So this is important. So when you see hypertensives who are under, fairly good control, BP is okay, but they have moderate or severe hyperretinopathy, and you see this clinically as the presentation goes on, you should be able to tell them that they have to continue and focus on keeping that hypertension under control, because otherwise there's a chance of stroke. Now, hypertensive retinopathy, interestingly, is associated with certain specific stroke subtypes based on the clinical retinal picture. This is a little tough one. Perhaps, anybody answering this should go and get a special prize. So we shall just keep an eye on that. So, either of you, can you tell me a retinal arteriolar narrowing is associated with which type of stroke? If anybody does this, I'll be pleasantly surprised. This is a tough one. Anybody at all? Okay. All right. So retinal arterial nerve narrowing is also associated with lacunar strokes, retinal hemorrhages with cerebral hemorrhages, copper and silver wiring. Would anybody like to take this? Okay. Specifically with atherosclerotic cerebral infarctions and hypertensive retinopathy, arteriolar disease with lacunar infarcts. So if you're doing very well, you might just get this, and you could impress your examiners with this. You can just drop a few of these. So this is important. Coming to cardiovascular disease and hypertensive retinopathy, this is intuitive, the association. So presence of hypertensive retinopathy associated with multiple markers, just coronary artery calcification, aortic stiffness, left ventricular hypertrophy, carotid media intima thickness, and hypertensive retinopathy associated also with obviously congestive heart failure. Now, why is eyeing the retinal vasculature bang for the buck? So this is something which one must also impress for not just us but our physician colleagues also, that the retina is the only place in the body where one can directly view the microvasculature, arteries and veins. And this is because the retinal and cerebral small vessels share a common embryological origin, common anatomical features, and physiological properties. And indeed, retina is the window to the brain. Again, a question for the hot seat students. Uh, as an early predictor of hypertension, generalized retinal arteriolar narrowing may precede and predict hypertension. So, a decrease of how much of the retinal arteriolar caliber is associated with an increase of BP by how much. So, there is a correlation. Can any of you answer? All right. So this is the correlation. Decrease of about 3 microns, 3.07 microns of retinal arterial caliber associated with the increase of BP by about 10 millimeters mercury. Okay. Now, something simpler. Can you name some of the risk factors when you think of hypertensive retinopathy? This should be straightforward. So, Pooja or Akshita, any of the risk factors for hypertensive retinopathy, and which is the most important risk factor?
So, high salt intake.
Sorry. Okay. Right.
High salt intake.
Yes.
Smoking.
Okay.
Male gender.
All right. Okay. So importantly, the most important one has been shown to be the duration of the elevated blood pressures. So that is very important. That is an important history to ask. Okay. Of course, coexisting diabetes, obesity, stress, smoking, alcohol. Family history is very important. Dietary factors, and of course, a few ocular factors like glaucoma and AMD. Okay. Right. Now, etiology. So you have essential hypertension, which is like primary hypertension, and then you have hypertension secondary to causes. So, Pooja and Akshata, can you name some secondary causes secondary to, say, adrenal disease?
Pheochromocytoma.
Yes, very good.
So, Cushing's.
And
Cushing's.
renal arteriolar
stenosis. Yes, yes, yes.
Atherosclerosis.
Yeah. So when you have hypertension, it's important to direct them to a physician to look for these causes, because you can't treat hypertensive retinopathy unless you reverse hypertension, unless you look for causes which it is secondary to. That will you won't be successful. So this is important. And let me also focus on the last one, obstructive sleep apnea. Over the last probably half a decade or less, we've begun to understand that how obstructive sleep apnea is becoming a critical factor. Many physicians are now directing patients towards doing sleep tests to look for this. So just keep that in mind. Okay, so this is again important basic, let's say almost undergraduate level. So what are the classifications available for hypertensive retinopathy?
Keith-Wagner-Barker classification and the Sheets classification.
Yes, and a more modern one?
Wong and Mitchell classification.
Yes, very good, very good, very good. So these are the three. So Sheets was what we began with, and Keith-Wagner-Barker was very popular and followed for a long time. But more recently, everything's been integrated, and we see how they reconcile to each other amongst the classifications. So let's look at. So you mentioned Sheets. So can you list out what the features are in Sheets classification?
Sheets classification, they divided the based on the
grades, yes.
Based on the hypertension and based on the arterial sclerosis. In the based on the hypertension, in the 0, there is no arterial changes. In the grade 1, there is a diffuse narrowing. In the grade 2, there is a focal narrowing. In the grade 3, there is focal and diffuse narrowing. And in the grade 4, there is exudates, retinal edema, and the optic disc edema.
Most important for grade 4 is optic disc edema. So this is well, more or less right. So in grade 0, of course, no visible retinal vascular abnormalities. Grade 1, barely detectable. Grade 2, diffuse arterial narrowing, focal irregularities, and then this is where you start seeing the light reflex changes. Grade 2 is where you have a grade, 3 is all that with grade 2, but you start seeing a lot of retinal manifestation. You have spots, and you have to see this pop-up wiring. And grade 4 is optic disc edema, okay, with the silver wiring of the arterioles. And Keith Wagner is a little more simpler to remember. Grade 1 is minimal generalized retinal arterial narrowing, 2 definite focal narrowing and AV nipping. Grade 3 is 1 and 2 along with, as I mentioned, hemorrhages, corniforms, exudates, and grade 4 is all that in grade 3 with optic disc edema. Now, so Wong and Mitchell is what everybody generally follows nowadays, contemporary. So what are the grades in this? Pooja or Akshita, anyone?
So mild, moderate, or severe?
Yeah. Okay, so that's critical. And a bunch of signs, almost somewhat similar. So in the mild, as we mentioned, general of focal arterial AV nipping copper wiring combination. And this is associated. Why this is important is because they gave a direct association between the signs, the grades, and the systemic status, systemic emotion. These were associated with a modest risk of clinical strokes, cardiovascular mortality. Moderate, once you start seeing those florid retinal features, hemorrhages, corneal spots, etc., there is a stronger association with strokes and cognitive decline and death from cardiovascular causes. And if malignant, which you've seen in grade 4, moderate retinopathy with swelling, there's a strong association now with death. So this is important. When we look at the slide on malignant hypertension, we'll see, look at the stats there. So how do you reconcile these? So as you see, compare Wong and Mitchell with Keith Wagner and Parker. This is how it is. So the mild comes or overlaps with grade 1 and 2, moderate with grade 3, and malignant with grade 4. So retinal hypertension and the retinal vasculature, the pathophysiology. Let's go a little deeper now into this. The retinal blood vessels differ from most other vessels in the body in A, the absence of sympathetic nerve supply. And would you like to add two more, Pooja or Akshita? One is absence. Maybe I left that out. I should have asked you all three. But
presence of blood-brain barrier.
Yes, that's good.
Blood retinal barrier. And
yes. Very importantly, autoregulation. Okay? Autoregulation, this is important. This is the ability of a tissue to maintain a relatively constant blood flow over a range of blood arterial pressures. This is important. And thirdly, as you rightly mentioned, blood retinal barrier. Now, why is this important? Because see, when you're extremely stressed or subjected to a lot of under duress, so you're having a headache, your temples are throbbing, your throat's running dry, all that is happening, but your vision doesn't change a lot. Even when you're under stress, your exam time or whatever, even right now as I'm in hot seat, your vision is stable. So all this is largely down to this point number 2, autoregulation of blood flow. So the retinal milieu, the vascular milieu is constant. So your vision is not changing minute to minute. That is stable, and that is largely down to this very important function of autoregulation. Now, clinicopathological stages of hypertensive retinopathy. We're getting into the clinical aspects now. So serial microvascular changes in hypertensive retinopathy are broadly divided into 3 stages. So can you tell me what these 3 stages are broadly from a pathophysiological point of view? Akshita or Pooja?
Vasoconstrictive phase.
Yes.
Vasoconstrictive phase, and then exudative stage, and then the permanent narrowing.
Sclerotic phase.
Sclerotic phase.
That's intermediate. Yeah, that's right. So you have the vasoconstrictive phase, then the sclerotic phase, and of course you can go ahead, of course, with the exudative phase. So these are three important components. We look at these individually. Okay, so in the constrictive phase, the local autoregulatory mechanisms come into play. So this initial response is vasospasm to hypertension. There's an increase in the vasomotor arteriolar tone. Okay, as you can see, what happens then is there's a consequent narrowing of the retinal arterioles to ensure regulation of the optimal blood volume. Okay, and all this results in clinical picture of generalized or diffuse retinal arteriolar narrowing, which you see in the preliminary phases of hypertension. And pictures, as you can see here, pictures like this is what you see. Now, when you move to the sclerotic phase, the persistent increase in BP leads to intimal layer, you have thickening or atherosclerosis, as you can see. In the medial layer, you have hyperplasia. There's a proliferation of the cells, as the vessels trying to counter the hypertension. And in the arteriolar wall, the decomposition will leads to hyaline degeneration. Okay, so you have all these three things happening, and clinically, what is then happening is diffuse and localized retinal arteriolar narrowing. So the next stage, next grade, grade 2, and you have now copper or silver wiring, and you have arteriovenous nicking, and this spawns three signs which we know, three named signs. So can you name these three signs which are a favorite of examiners and something?
Salus sign, gun sign, and bonnet sign.
Yeah. So can you tell me what these are specifically?
In the Salus sign, there is a deflection of the arteriole at the AV crossing. No, after
The deflection
AV.
of the arteriole. Is it the arteriole which is deflecting?
No, sorry, venules.
Yes, right.
And
Okay.
in the gun sign, there is a tapering of the venules just at the AV crossing, just before and after the AV crossing, and at the bonnet sign there is banking of the vein. Means bonnet sign,
Right.
I am not too much clear.
Yeah. Right. Quite close. Pretty close. Okay. So that's that. And just to illustrate this a little more figuratively, so this is gun sign. There's a tapering of venules on either side of the AV crossing, as you can see in the clinical picture. Here, there's a copper wired vessel there, and you see the vessels tapering, the vein. So it's a venular sign. So all these signs are venular. Okay, so you can see the tapering of the vein there. Okay, towards that, and it's shown pictorially here. On the other hand, you have Salus sign, where there's a deflection of the venule as it crosses the arteriole, as you can see again here. Okay, a sclerotic vessel here, and this vein which should have gone like this is pulled. It's like, if you have a metal rod over a pipe, the moment you put it over that pipe, the pipe, because it's stretching the wall, it's compressing that wall, that pipe will move towards the metal rod. So it's exactly what is happening here. You can see that this sclerotic vessel is pressing down on the vein, and this vein should have gone like this, is pushed here, and that's what you're seeing there also, and that is Salus sign. Okay, and on the other hand, you have gun sign. When you have the bonnet sign, which is this banking of the veins distal. Okay, distal to the AV crossing. So you can see that clear sign of banking. All right. So I hope that is clear. Right. We'll move on to the exudative phase, where, as you quite correctly mentioned, all that exudation is happening. So basically, why does this happen? There's disruption of the blood retinal barrier, as necrosis of the smooth muscles and the endothelial cells. Okay, and then you have these micro deficits happening in the vascular wall, and this leads to leakage of plasma lipids and blood, with concomitant retinal fiber layer ischemia and axonal swelling, which is why you get the cotton wool spots. Okay, and all this is seen clinically as microaneurysm, heart exudates, hemorrhages, cotton wool spots, and also serous macular detachments, as you can see here in this picture. Yeah, so you see clinically microaneurysms, heart exudates, as you can see here, cotton wool spots, as you can see there, and you can see this macular detachment. I hope you can make that out on your screens. You have this exudation also happening. Now we'll move on to clinical grades and signs. Okay. And this is grade 1, hypertensive retinopathy, okay, where there's generalized arteriolar narrowing. Then this is grade 2, with severe generalized and focal arterial narrowing and EB crossing changes. And grade 3, this is where it's easiest to recognize and most typical and classical. Grade 3 hypertensive retinopathy, where you have copper wiring of arterioles, venous banking, tapering at the edges, as I mentioned, flame-shaped hemorrhages, bottle spots, and FIPTs. So, either of you, what are FIPTs? Do you know the full form? This is something, again, I've noted it. I remember at least one examiner my time who was very fond of asking this particular question. So can you give me the exact full form? Any one of you, Pooja or Akshita? Or if anybody else wants to type it out, all right. So it's focal intraretinal periarteriolar transudates. Okay. These are large corneal spots. This is an example of an FIPT. It's large, very large ones. Okay. And of course, you also have hard exudates, as I mentioned earlier. Grade 4 hypertensive retina, this is the most serious and most lethal form. All these changes that I mentioned of grade 3, alongside silver wiring, and importantly, disc edema. So the hallmark here is really disc edema. So that's what, once you see this, you have to immediately classify. And more often than not, almost always, in fact, it's bilateral, or at least asymmetrically bilateral. So now, so we've come, kind of run across the entire gamut of hypertensive retinopathy, hypertensive changes in the retina and the eye. Let's look at the choroid. So hypertension, when it happens, it's not just hitting the retina, it's in choroid also and hitting it significantly. A severe uncontrolled hypertension leads to fibrinoid necrosis, followed by infarction of choroidal vessels. You have choroidal ischemia happening, shows up essentially at the level of the choriocapillaries. And you have RP pigmentation and RP hyperplasia, which we see first up, clinically. And what does this manifest as? So again, like I mentioned, all this is happening at the level of the choriocapillaries. So Pooja and Akshita, let me just point out this and this sign here. What are these? If you can see my cursor.
The
What are the
second
signs of
one,
hypertensive choroidopathy?
second one is the Elschnick spot, and this first one that you shown is the Segrist streak.
What is this?
She
Well, right, you're
Segrist
right, you're right. Yes, yes,
Segrist.
marks for you in there. Yeah, correct. So you have spots and you have streaks. Just remember that. And this is again an examiner's favorite. So you have Elschnig spots, which are, as you can barely just make out, just manage to capture one. These are rare. These are not common. So it's not easy to get this, but when you do, and this usually is sometimes seen in patients who have been through various, episodes of accelerated hypertension, chronic hypertensive, long-standing hypertensive, and you can see this carefully. When you see this, you should know that this patient has been through, that kind of a difficult phase with hypertension. These are hyperpigmented patches in the choroid here, as you can barely make out here, surrounded by a ring of hypopigmentation. And Segrest streaks, on the other hand, are linear pigmented lesions over choroidal arteries. That's important. Okay, it's over choroidal artery. Okay, so that is there. Then you have hypertensive optic neuropathy, which is, again, like I mentioned, a very lethal, very serious manifestation of hypertension in the eye. Severe or malignant hypertension, grade 4, there's a rise in intracranial pressure, leakage and ischemia of the arterioles supplying the optic disc. These undergo fibrinoid necrosis, and this leads on, if left untreated, optic nerve ischemia. And clinically, this manifests in the acute phase, as you can see in the picture here, optic disc edema and hemorrhages. In the chronic phase, obviously in the late stage as hypertensive, as optic disc pallor. And when you see this, what is most important to do is to control the BP urgently, suspect possible hypertensive encephalopathy, and an urgent referral to the physician is mandatory. Very big, it's something you have to do. Okay, so coming to complications now. All right, so apart from these manifestations in the retina, in the choroid, in the optic nerve, how else can hypertension what else can hypertension lead on? Specific pathology. So either of you may, let's say, Pooja, what is this? What are we looking at?
Hemorrhage, disc hemorrhage.
No, what is the pathology? You can see something happening all around the retina. Is this the normal color of the retina?
No.
So what is this?
You can check the chat box also, Dr. Anand. There are answers.
Oh, I actually, because I'm on the full screen, I've kind of minimized all that. So,
So we have CRO, cherry red spots by Ekta
Okay.
Sen, Anita, splinter hemorrhages by Ekta.
Okay. Good. Because it's difficult to so, the chat box because I'm on the full screen here. So that's what. Good. So people are answering. That's good. So this is a central retinal artery occlusion, and very clearly you can see, the diffuse retinal pallus. This is absolute pale retina in a fairly acute stage, and you can see the cherry red spot there. And this is something that moment this happens, obviously, this is a absolute ocular emergency. So we have only a handful of ocular emergencies that we have now, but this is something that mandates immediate attention and action. And then what is this? Yeah, what is this? What are we looking at here? Akshita or Pooja or anybody else can jump in. So this is the normal retinal
Branched.
color. What? Yes, you're close. Yeah.
Branched retinal vein occlusion.
Is that a vein occlusion?
Oh, sorry, sir.
Vein
Artery.
occlusion
The
pallus?
branch retinal arterial occlusion.
Right. Distributed branch retinal arterial occlusion. Okay. So this is a very florid picture. Okay, you can see the ischemia out there. All right. So what are we looking at now?
Central retinal vein occlusion.
CRVO.
Correct. CRVO. And what is this? What are you seeing here in the optic disc?
NVD.
Is it NVD? Look at the caliber of those vessels. Okay, so it is CRVO. All these are CRVOs. And this is a non-ischemic CRVO with collaterals.
Opticillary
Okay, so
vessels.
collaterals. Yes.
Hmm.
These are collaterals, yes. The shunts are right there. And what kind of a CRV would you call this?
So ischemic
So
CRVO.
this is hemorrhagic. Okay, so I can see the answer. It's covering that. All right. So fine. So that is there. And then what is this?
BRVO.
Correct. And what are these that you see?
Collateral means
Correct. Yeah. The supratemporal BRVO with collaterals coming from the inferior hemisphere. Okay, so there's a compensatory effect. The retina is trying to perfuse the perfused area from the opposite side. So this is mixed retinopathy, and this is something which you see quite commonly actually. Diabetic patients with diabetes having hypertension also, and you'll have this mixed bag picture showing up. So you should also be familiar with the fact that patients can present with a mix of both. All right. Okay, so what is this? Hello.
disc edema.
What are we looking at? Obviously, something is happening in the disc.
Disc edema.
Yes.
Hypertension.
What kind of a disc edema is this? Is it how would you describe this edema?
Ischemic aortic neuropathy.
Correct. So what is it? What is that pathology? What is it commonly? What is the common term for this? And see this fluorescein angiography. What's happening at the fluorescein angiography? Stark. It's pretty stark.
Anterior ischemic.
Yes, it is anterior. So what is the classic, fluorescein angiographic hallmark of this? Okay, so there's sectoral hypoperfusion, the optic disc, and this is typically pallid optic disc edema. Okay, you're seeing a very pallid optic disc, and that is the absolute hallmark of AI1. Okay, so this is example of ocular ischemic syndrome, and you can see a florid acute form of that here. All right, yeah. So just to cap it all, sum it up, you can have several complications with hypertension, vascular abnormalities, CRAOs, BRAOs, CRPOs, BRVOs, microaneurysms, mixed retinopathy, AAO, AMD, and PCV bleeds, glaucoma, ocular ischemic syndrome. Okay. Now, malignant hypertension, we've talked about this already. What is it exactly? How do you define this? So, Pooja or
More
Akshita,
than
how do you define it?
systolic more than 180 and diastolic more than 120.
Right. We saw that in the initial classification, the JNC report, 180 and 120. So that is right. 180 and 120. And symptoms being eye pain. Patient will come to you with eye pain, headache, sudden blurring of vision. This thing is fine. He look fine very often. And this happens very often in young patients who are stressed or, there's a family history. Uh, it's not uncommon to see this in young patients actually. 180, 120 coming with very sudden blurring. When you go and see, check the BP, you'll be shocked to find 200, 120. These are associated with cardiac abnormalities, tachycardia, acute kidney disease, stroke, neurological symptoms. And this is what I want to tell you, that the issue here is that there's a very high association with hypertensive encephalopathy, that leading to mortality. And untreated, 80% of them can die in 2 years. This is why this is so important. The diabetes, we have diabetes for a long time. It's fine. It's important to treat diabetes, but hypertension is an absolute killer from the absolute literal word, so literal speaking. So untreated hypertension patient will be walking in, will be absolutely fine. But if this is the situation, then he has to be warned, and you need to give an urgent reference to your physician. Okay. This is a clinical picture. This is a patient who had actually walked in. Again, a young patient who came in like this with high BP, with again the same exact thing that I mentioned: the eye blurring of vision, slight headache, throbbing headache. And this is his picture. You see disc edema. You can see macular edema, and the edema is actually pouring off from the disc. So there's more edema, as you can see in the pictures, both on the nasal macula than the temporal macula. That's a giveaway sign from the OCT. Okay, and you can see the multicolor images also showing there. And just by controlling BP, you can see fairly remarkable resolution of the clinical features. The optic disc, both edema just vanished. You can see the florid resolution of the clinical features, retinal and optic disc. Now we come to pregnancy-induced hypertension. This is an area which is not very people people come across this, but it is important to know. Preeclampsia or PIH affects 6 to 8% of all pregnancies, generally resolves after delivery. Usually happens. Clinical features, retinal choroidal vascular features of hypertensive retinopathy. Serous retinal detachment might be seen in severe choroidal ischemia. Transient cortical blindness happens secondary to cerebral vasospasm. Okay. And treatment is specific treatment for the ocular manifestations of PIH, generally not indicated. And systemic treatment of PIH consists of antihypertensive therapy, magnesium sulfate, and early delivery of the fetus when indicated, and that's obstetrician's follow-ups. Now, what are when you come to imaging, ocular imaging of relevance in hypertensive retinopathy? What are the couple of things that you would like to do immediately when you see a patient with hypertensive retinopathy, especially grade 3 and 4? Pooja, Akshita, very quickly. Let's say first things to do are the non-invasive ones: fundus photograph and OCT. Okay.
OCT.
So this photograph is important for serial monitoring, as you've seen, especially that malignant hypertension, how it resolves. So you like to get a quick picture. If the BP is not too high, get a quick picture, get the OCT that tells you. It helps explain to the patient also. You can document the neurosensory detachment, macular edema, the thinning of the inner retina, and focal attenuation of the ellipsoid zone in areas of these elation spots. Also, one can do Opta. This will show, as I mentioned to you earlier, it is a choriocapillaris which takes the first hit. So you can see moth appearance of the choriocapillaris signifying areas of non-perfusion. Fluorescein angiography, not very critical, but especially if somebody is going in for an impending CRVO, or there is a doubtful nevascularization secondary to vascular occlusion, you could do that. You'll also find in hypertension, especially sometimes we see this in the fellow eye, case with say a CRVO in patchy and delayed choroid filling and severe delayed retinal arterial filling with case of retinal non-perfusion, and in Elston's conjugate sign, them showing up as areas of early hyperfluorescence with late subretinal leakage. ICGA, on the other hand, will help show areas of hypocyanescence of the ischemic areas of the choroid and tells you that the choroid is also being impacted. Some new imaging modalities are also there. These are all good to know, great to know rather. So would you like to just take a shot here, Pooja or Akshita? These are all only if you're doing very well in the exams will you be asked this, or should you be asked this. So Doppler OCT helps show up monitor retinal blood flow. These are largely in the domain of research. Retinal oximetry to monitor retinal oxygen saturation. Adaptive optics help measure wall to lumen ratio. These are all great to know things, so just for you to know additional. So investigations that need to be done, obviously, if patients are very severe hypertensive, echocardiography, electrocardiography, serum electrolytes, urine creatinine, urine analysis, lipid profile, glucose, and HbA1c should be checked because you can always have people having concomitant diabetes. So just some etiology specific investigations. So chest X-rays are sometimes asked by physicians, and what are they looking for? More like a medicine quiz here. So only high marks if you answer these, otherwise it's okay. So chest X-ray, what can it show you? Pooja, Akshita, or anybody?
Left ventricle hypertrophy.
You're right. The most important is coarctation of the iode. Okay. And dexamethasone suppression test or urinary cortisol. I think you had answered this particular pathology earlier.
Cushing's test, Cushing syndrome.
Yes, Cushing's syndrome. Very good. And plasma renin to aldosterone ratio. This is fairly obvious for primary
Hyperaldosteronism.
Yeah. And this one, urine metanephrines, again, something you had answered earlier.
Pheochromocytoma.
Correct, absolutely. And this, of course, calcium and parathyroid same for hypertension. Yeah. So finally, management, and this is just a nutshell because this is mostly the domain of a physician. So we have to collaborate and work with them. So in mild hypertensive retinal Wong and Mitchell classification, lifestyle changes, routine BP monitoring, and the patient has to be urged to have better control of hypertension. So these are things that you can do, and this a lot of patients will come in with this range, okay, of hypertensive retinopathy. This is what you can do and stress upon. When it's moderate, it's important to immediately get a blood investigation workup, a good diabetic profile, cardiovascular workup. Physician may be required and should be done. And of course, it's severe, then it's urgent to refer to physicians do a proper workup for target organ damage, renal, brain, and cardiovascular. Okay, so thank you. With that, I'll stop. I hope this session has been helpful and you've taken some useful points from this. Okay, so Vishal, I'm kind of done. I think I'll stop sharing here. Okay. Right, I think kind of on time. Okay, now I'm seeing the chat box. A lot of people have answered. So Vishal, are you there? Is he around?
Dr. Rajendran, I am here. Vishal is
okay, Dr. Gulam. Okay. Right. Okay. So yeah, so I hope, does anybody have any questions or any doubts or any interesting experiences to share or anything like that?
Sir?
Yes.
Sir, in banking sign, the vein come towards the arteriole. Means what is it?
Sorry.
In the banking sign,
Want me to show you the?
in the bonnet sign.
Yeah.
The banking of the venule circle means it means the venules comes towards the arteriole side.
We are talking of which one? The
Bonnet.
bonnet sign?
Yes, sir.
Yeah, that is banking. Yeah, no. When I said coming towards, that was the Sanu sign. That is the deflection of the venule towards the arteriole, which is crossing it. Okay.
Okay.
The other one is
Mm.
banking is distal to the vein. I think I showed you the picture, isn't it? You can see that bulging of the vein distal to it. That's important because vein the flow is in the reverse direction, isn't it? Towards optic to the AV crossing rather. Okay. So, any other questions? Oh, no. No, Dr. Gulam or Dr. Vishal, either of you are here. Anything you would like to
I
add?
am here.
Do we do the quiz or would it?
Rajendra, you can do quiz now, no? I think there is no question from audience.
Okay. So, I hope somebody is tracking.
Yeah, I am tracking it.
Okay. Good. Vishal is not around because he's
Vishal is just coming
also
actually.
steering the session. Okay. All right. So just shoot off based on this presentation. Some questions. So first of all, let's see how many of you have been really keyed in. So the first question that I asked, what is the for hypertension per se? What is a systolic BP and diastolic BP uh, as defined by WHO? That was the first question I'd asked. Okay. All right. See, Siddhi Mathur is the first.
Yeah, Siddhi Mathur is the first.
Okay.
Right.
All right. Okay. So going forwards, let me what is the stage of hypertension where you have target organ damage from the JNC report? Stage of hypertension, not grade of hypertensive retinopathy. I said stage of hypertension. Yes, Akshida, the measure is right. Hypertensive emergency. That's right. All right. And okay, so hypertension accounts for about how many deaths per year annually? Rough figure. Yeah, about 10. Correct. Puja is fractionally ahead of the thing, but yeah, Akshita is more accurate, so you get split points on that. Okay. And in developed countries, what percentage of the population is expected to have hypertensive retinopathy by 2025? Developed countries. Developed. I think Vinesh Sharma has got it right. 80%. 80%. That's a scary number. Absolutely scary number. Okay. And what is the, how many fold higher is the risk of stroke in patients who have well controlled hypertension but with moderate to severe hypertensive retinopathy? How many times higher? Yes. Mathur again, three times higher. All right. And does anybody remember retinal arteriolar narrowing being associated with which stroke subtype? So really, this is really testing how attentive you've been. Yes. Again, Pooja and Siddhi have cracked it. Yeah, lacunar. That's right. All right. That's good. Okay. And we'll move on from there to All right. So if there's an increase of a decrease of 3 microns of retinal arteriolar caliber, how much will your BP be expected to increase? Oh, a lot of them. It's pretty huge number of people. Yes. Okay. And which is the earliest sign of hypertensive retinopathy? Earliest clinical sign. Let's put it this way: earliest vascular sign. It's actually, yes, Vinny Sharma has been pretty attentive. It's venular widening. Everybody thinks of narrowing and arterial narrowing, but the first thing is actually venular widening. All right, that's good. All right. And which is the most, important risk factor? Most important risk factor, which I mentioned. Now, Akshita is duration. It's not just the elevated blood pressure. Everybody can have high BP. If I asking you a question, if I'm asking Pooja or Akshita, their BP might shoot up. So it's not just that number, but it's how long you stay at that number which is important. So the duration is that's important. All right, and let's move on to, so which is the most contemporary grade of classification of hypertensive retinopathy, contemporary, the one which we are following currently. Correct. Siddhi Mathur again, I think she's attentive and she's typing pretty fast. Wong Mikkel. Correct. Right. All right. So in which grade of let's say She's classification would you get the silver wiring of arterioles? Yes, right. Vanchika Arora, it's first for even Anita. Yeah. Right. Okay. All right. All right. Okay. So, what is the reason our vision doesn't change in hypertension? What is that pathophysiological mechanism? We talked about this. What is that pathophysiological mechanism which causes the blood flow in the eye to be more or less same? Yes, Gagandeep is seated first, along with Manshika. Auto-regulation. Yes, auto-regulation. Yeah, so a lot of people on 2023. Manshika, Anita, Gat. Good.
Congratulations, Jagandeep.
Yeah. A lot of them. 2023, there are 4 or 5 people.
It was a simple question, that means.
Yeah. Well, they've been very attentive. All right. So, okay. So all right. I won't make it a very long question. All right. So, what happens to the arteriolar wall in the sclerotic phase? What is the exact pathophysiology that's happening? Or arteriolar wall. I didn't say the medial layer. Arteriolar wall. Yes, hyaline degeneration, hyaline arteriosclerosis. Divya has got it there. All right. And now, clearly, okay. Which is that sign where you have tapering of the venules on either side of the AV crossing?
This is your third question, sir?
This is probably my 20th question.
No, but these are prizes. We'll be empty of the prizes. No, that's what.
You just put a count. You just count. I was ad nauseum while you were away. While you were raiding the
I just had
kitchen.
an
While you were...
emergency to attend to, yeah.
Oh, I thought you were raiding the kitchen. Okay.
No.
All right. All right. And what about deflection of venules? Which is the sign which okay, Salu, all right. And obviously banking. All right. All right. Okay. All right. So that's pretty good actually. And Okay, so Segrist streaks are linear hyperpigmented lesions over what specific anatomical structure? What specific anatomical structure? I mentioned this. Everybody's coming. Not. I see one person. Shita has it right. Choroidal arteries. So they are linear pigmented lesion over choroidal arteries. Okay, that's important. All right. And what are those hyperpigmented patches? Mentioning. All right. Nakshita, Ekta, Anita. All right. All right. So fine. I think. And finally, malignant hypertension. What is systolic, diastolic?
One eighty.
Okay. All right. Okay then. I think that's it.
Excellent.
That's it. This game up. All right.
We
All
have
right.
a lot of
So
prizes.
finally,
Yeah.
So Vishal will be the decider. Vishal and Dr. Gulam will be the decider.
Yes, I'll decide
Guess
and
what?
create the list.
Yes. So he's the one with the money bags. So he'll decide. All right. I hope you guys have enjoyed it as much as I
So,
have.
sir, this has been a wonderful Kaksha by Dr. Anand Rajendran. It's a vast topic and it is impossible to cover everything. But it was a very well explained and a very comprehensive and crisp presentation. Thank you all residents and ROS executive and teachers, and especially Anand sir for the excellent teaching. We look forward to the next class in the coming weeks. Thank you and keep giving your feedback and suggestions for the Kaksha to improve. Do subscribe to the ROS official channel on YouTube. All the previous Kakshas are uploaded there. Good night from Team ROS. Thank you, sir. Thank you again.
Thank you. Pleasure.
Thank you.